Thank you all for your time this afternoon. We'll jump right in. So this is us here in Columbia, South Carolina. We function more as a community program, but we do VADS, and we've been doing Barostim since 2021 for a variety of reasons that were already mentioned. So medical therapy obviously is the foundation for heart failure. We've been doing 4 pillars since 2019 when SGLT2 inhibitors made their splash. The challenge there, as was noted in Evolution HF, is there's a significant discontinuation rate at 12 months. But if you look at the rate of discontinuation, it's substantial in that first 0 to 6 months for a variety of reasons: intolerance for blood pressure, affordability, just patients can't take all the medicines all the time. And previously, what we did was we said, well, you're not quite sick enough for VAD or transplant, but you're still pretty sick here, and we'll keep trying different medications, and you add a half a tab here of something or a little digoxin here, and patients continue to get worse. We've done that for years, and we've watched them with our remote monitoring system with CardioMEMS primarily. And when we had the opportunity to look at Barostim, we said, well, perhaps this is something where those patients that are in that gray area that we don't have a great answer for, maybe it'll work. And it's done remarkably well, and I'll show you some of our data. And so with that, we've started developing our device program here, not only with Barostim, but also with CCM. And it's simple, right? We've all done this here with VAD programs or transplant programs and remote management programs. The part here of developing this, though, is to coordinate it so that you can start intervening earlier. As Dr. Gupta was mentioning there, you're starting to see these patients before they get to VAD and transplant, and so we can offer them this device to hopefully maybe prevent them from needing that or at least delay it. And then organizing the team. It's really simple, right? We've got a bunch of heart failure cardiologists. Anybody that's in one of these programs has a surgeon that wants to cut on somebody, and they can implant the device. And it's very easy, 30-minute procedure. They love it because it's simple and effective, and the patients go home the same day. And then standardizing the evaluation, as was shown, the titration that was previously shown as well, makes it very simple, very straightforward. We usually have these patients come in every 2 weeks for about 2 months. They get titrated. Usually by the second or third titration, they're noticing a substantial difference. And then after that, they just kind of fly, and we tell them to come back in 6 months. And then course correct with medications. This you've already seen, but I wanted to emphasize the importance to the intolerance to GDMT. Again, 4 pillars of therapy for the foundation for heart failure, but we're really struggling to keep those patients on it. And we try very hard to titrate therapies. Love Entresto, great blood pressure lowering medicine, but you get a 75-year-old and you try to titrate up to the highest dose, and suddenly you have a hypotensive 75-year-old that's falling and hitting their head on anticoagulation. So there, I think, are a lot of discrepancies between what we see with the clinical trials and what we see in clinical practice. And I emphasize this because I think there's a greater need for device therapy in those patients. So pre-implant evaluation, it's simple. It's so easy. Most of this stuff you already do in your clinics. And then what we look at is some of the stuff just to keep track of folks in terms of NT-proBNP. When we looked at it initially, we were getting similar results to what we're seeing in BeAT-HF of about a 25 to 30% reduction in NT-proBNP, getting the carotids and then a surgical assessment. And then we have our administrator that helps us with our device program to schedule the implant for the patients. There's the titration, looks pretty similar to what you just saw. We don't really change any neurohormonal blockade, though, for those patients as we're going through. We really just make changes to diuretics, and I'll show you some reasons why here in a bit. But once they have finished their titration, what we have noticed is either a stabilization of blood pressure or a little bit of an improvement where we can add some GDMT back to those patients that they could not tolerate previously. And BeAT-HF, when you looked at it, unfortunately, it didn't meet its endpoint with hospitalizations. Probably a lot of different reasons anytime you're performing a trial that's occurring during a pandemic. But we've followed our patients pretty closely here, and you can see we have a substantial reduction in hospitalizations for our patients. And this is what we've noticed. You can see these are patients that we've had for at least 1 year looking at pre-implant and post-implant for these folks. And then most recently, we were looking at diuretic utilization because we kept seeing that we had to back off diuretics for our patients. And you can see consistently as they move from 3 months to 12 months, a reduction in diuretics, but it's most substantial at 12 months. And I think that's partially because you've got to titrate this device, obviously, in the first 2 months. But there is a little bit, I think, of a delay in the impact overall here. And then what I like to do is just point out this case study that we had in terms of diuretics. This is a gentleman that we implanted and did a blood volume analysis. And you can see here that he had a significant excess in his blood volume. Now, he couldn't tolerate all GDMT, so we placed the device. He was feeling wonderful afterwards, but he went from Lasix 40 daily to once a week, and you can see the substantial change in his blood volume overall. And again, just a remarkable outcome for him. He's actually now living in the Philippines because he left after he felt so well. So in addition to expanding the window that we've seen, I think we are also improving outcomes for our patients. They are feeling better. They are staying out of the hospital. They're needing less diuretics. All of those are markers that heart failure is improving that we would like to see for all of our patients. So a few things that we've learned. Earlier is better. I agree with Dr. Gupta. This is not the therapy to bail out your inotropes and LVAD folks. We've certainly tried that early on after we had some really good super responders, but they don't thrive. They do okay, but they don't thrive. So if those folks need a VAD or transplant, that's just what they need. But your late class 2A or early class 3 is ideal for these patients. Develop a protocol so that you can titrate quickly. We had patients early on when we were titrating them once a month. They were kind of a little frustrated because they weren't making a whole lot of progress. And as we titrated quickly, they felt better. Just allows a little bit quicker alleviation of heart failure symptoms for those patients. It's very well tolerated. We've not had any significant hypotension, no significant bradycardia. People often are concerned about those side effects, but we have not seen that for any of our patients. And then afterwards, course correct, right? If you have the ability to add GDMT back in, you should do so, obviously, as those are the foundations for heart failure care. So in summary, these are the patients that we want to target. It expands our therapeutic ability, and then we've had great results with the device therapy.